The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/RQF860. Downloadable slides and practice aids are also available.
Good evening, everyone. It's great to see everyone's smiling face out here tonight in Denver. Looking forward to giving this presentation. Evan and I have been able to give it already several times, and it's great to be able to give it to my emergency medicine colleagues out here today. We're going to talk about best practices for recognizing and managing immune-mediated adverse events in the emergency department. I'm Andrew Stolbeck. I'm an emergency physician at Hopkins in Baltimore. I work 2 or 3 shifts a week, so I'm still out there working in the emergency department. I'm also a medical toxicologist, and so I take call with the Maryland Poison Center. But all of this has been very clinically meaningful to me because in the last few years, I've started to see a lot of these patients come to my emergency department, and I bet that you all are also.
Good evening, everybody. My name is Evan Lipson. It's a pleasure to be here. I am an associate professor of medical oncology at Hopkins in Baltimore, along with Andrew. And my role tonight is to tell you a bit about the drugs that we're using and the way that they work and the way that they affect patients and how those patients might present to you in the emergency department setting. My specialty is skin cancer, melanoma and other skin cancers. But what we'll describe tonight is something that actually crosses all different tumor types because the therapies we're discussing today are used for patients with a variety of different cancers. And so what we're discussing is not just relevant to my patient population, but to thousands and thousands of patients being treated out there every day for various malignancies.
Really what we want to talk about today, this is an exciting talk because it's really paradigm shifting. So I graduated residency in 2002, right? I've just gone through my first recertification for emergency medicine a few years ago. And the paradigm that I always learned for oncology drugs had to do with, in the emergency department, had to do with cytotoxic chemotherapy. So what I learned about patients, cancer patients in the emergency department was that they would come to the emergency department and I would want to find out when their last chemotherapy was, and if it was within 7 or 10 days or a couple weeks, I was in a danger zone. We were going to see if they were neutropenic. If they were neutropenic, we were going to address that. If they're neutropenic with a fever, even more cause for concern. And that's really how we thought about it. But that paradigm is changing. Now, those drugs are still here, and for those drugs, that paradigm still holds. But today we're going to talk about a new group of drugs with a totally different set of adverse events that we're all going to be managing in our emergency departments. And the great thing about this talk today is that we're going to give you the tools to recognize all these adverse events and then to treat them with medications that not only do you have available, basically different corticosteroids, things that you're already using every day. So I think this is just going to be very clinically helpful. But the message we're going to tell you in the beginning, the message we're going to tell you in the end is right here. And that's first, when you take your history, ask about cancer diagnosis and treatment history. And as we're going to see, it's not just medications that they're taking today. It's going to be to ask about medications that they've taken in the past months or even past year. Number 2, to get in touch with their oncologist. Because whatever gaps there are in the patient's knowledge of what medications they're taking, the oncologist is going to be able to fill that. And they're also going to be able to help you pick therapy if they do have one of those immune-mediated adverse effects. We're going to help you generate a differential diagnosis. And what you're going to appreciate is that for every diagnosis we talk about today, there are going to be 5 common competing items in the differential that are things that you're already seeing every day. So for every patient that you see with, for example, immune-mediated pneumonitis, right, we're also seeing PEs and pneumonias. So we're going to help you build that differential and show you how these diagnoses fit in to things that you're already seeing. And finally, we're going to talk about treatment. And as I said right, at the beginning of this slide, the beauty is that the management of these adverse effects are drugs that you're already using every day. For the most part, just steroids. So Dr. Lipson.
Thanks. So I'd like to just begin with a brief introduction of what these drugs are about and kind of how they work, and just give you a sense of kind of what the names of them are and what to watch out for. All right, so let's talk about the patient presentation to the emergency departments. And if you have not seen these patients present to your ED yet, I imagine that you will in the coming months and years. So the key here for really the triage folks is to ask good questions about their cancer diagnosis and treatment. So have you had treatment for your cancer in the past year? Oftentimes we're used to asking, what are your current medications? It's important to keep in mind that it now becomes relevant to know what the patient has received in the past approximately 12 months or so for their cancer therapy. So this patient says, yes, I have kidney cancer and finished treatment 2 months ago. So that 2-month ago dose of whatever antibody he received is still in that patient's system and could still cause adverse events that we're going to discuss. So you ask, well, what was that treatment? And these names of these drugs that I'm about to show you are quite long, and so very frequently patients can't remember them, so we give them wallet cards. Those wallet cards typically look like this. They have immunotherapy up at the top. They'll tell you exactly what they have received, and they'll also have at the bottom the name of the treating oncologist. And so I know that I don't speak only for myself when I say that we would love to hear from you, the emergency department treating physicians, providers, because it's easier for us to start that dialogue early on and get on top of these things right from the get-go. So please do give us a call, contact our offices when these patients come in the door. So let's talk about immune checkpoint inhibitors, how they work and why they're called that. We'll start with a quick video.
This animation illustrates how some of the immunotherapy agents called immune checkpoint inhibitors work in the treatment of cancer. Cancer cells are able to evade recognition by the immune system, which allows them to survive. Cancer cells express PD-L1, which binds to PD-1 on T cells to turn off anti-tumor responses. This is called an immune checkpoint. Immunotherapy prevents cancer cells from inhibiting T cell attack. Anti-PD-1 antibody therapies block the immune checkpoint, allowing the immune system to recognize cancer cells. Anti-PD-L1 antibody therapies can also be used to block this negative interaction. Immunotherapy allows the immune system to recognize cancer cells, leading to anti-tumor responses and cancer cell death.
All right, so just to review, let's talk about the mechanism of action of the immune checkpoint inhibitors. It's important to understand how these drugs work so that you understand why the toxicities are the way that they are. So there's a T cell on your left. That is really the workhorse of the immune-related tumor response. On the right is the tumor or an antigen-presenting cell. And so what you see there is that the T cell receptor on the left side is about to meet up with its cognate antigen, which is some piece of a tumor that's being presented either by a cell itself or by an antigen-presenting cell. That initial molecular handshake that takes place between those two cells puts the T cell on alert that something is going on. At that point, the T cell has a decision to make. The decision it has to make is whether to go forward and attack what's in front of it or to back off and do nothing. The reason you want your T cells to have that decision is because if it were to bump into something that is normal tissue, it needs to know to leave it alone. So how does it make that decision? There are these regulatory molecules that exist on the surfaces of T cells and tumor cells that I have drawn here as red bars and green bars. These molecules have alphabet soups of names, PD-1, PD-L1, CTLA-4, and the list goes on and on and on. But essentially, the function of these molecules is to either stop the interaction between the T cell and the antigen-presenting cell, or to encourage the T cell to go forward and attack what's in front of it. Cancer has co-opted these pathways, and it presents on the surfaces of cancer cells one of these red bar stop signs. And so the immune system is tricked into believing that tumor is in fact self, that it is something that should not be attacked. So those two red bars are allowed to meet up. The tumor fools the immune system into thinking that the T cell should leave it alone, and the T cell does. The T cell does not attack the tumor. The drugs that we are using block that interaction. The drugs that we are using block PD-1, that checkpoint. It blocks PD-L1. It blocks CTLA-4. That alphabet soup list of molecules that regulate the way T cells activate, those are the drugs that those are the molecules that we're blocking by using our drugs. So when we talk about immune checkpoint inhibitors, we are inhibiting a checkpoint of an immune cell. Where are these drugs being used? Back in 2014, these medications began to get approved by the FDA for melanoma and maybe a couple of others. That list has exploded over the last 3 or 4 years, 5 years, and now is used in a long list of tumor types. And so that's why I said at the introduction that this is now affecting thousands and thousands of patients. And this list grows by the month or so. So this is called common denominator therapy, which means that these drugs are not targeted to a particular type of cancer. They are targeted to the immune system, and then the immune system goes and does the heavy lifting. It attacks the cancer. Some of the names of these drugs are quite long, and this is why patients have trouble remembering them. They're listed on the left. Ipilimumab is one, nivolumab, pembrolizumab, cemiplimab, atezolizumab, avelumab, durvalumab. They all kind of sound alike, right? They all end in mab because they are monoclonal antibodies, mAbs. They are not unlike other medications that also end in mab. For example, infliximab, which is used for patients with ulcerative colitis. In fact, that medication does quite the opposite of what these medications do. The reason this is important is because you can't assume that any drug ending in mab is one of these. They're often similar sounding names to other medications. So just to give you a sense for what you're sort of looking for are drugs that end in mab. These are monoclonal antibodies. And the details are, in this case, very important. You really do have to understand what drug is being given for what purpose. To complicate matters further, these medications are now being used in combination with other agents. So chemotherapies, other monoclonal antibodies that act in different ways, and then they're also used with radiation therapy and et cetera, et cetera. So this list also grows by the month.
Now, for the sake of pronunciation, I hear a lot of oncologists just saying like Ipi for ipilimumab or Pembro for pembrolizumab. Is that?
Yes, that's.
So like sound like I'm in the know when I do that? Or is that
you do sound like you've got some street cred if you call us and say, the patient's on Pembro. That in itself is confusing because you leave off the mab at the end, and so you don't get that clue that it's a monoclonal antibody. But yes, that absolutely happens. Even more confusing is that patients know these drugs by their trade names because they see them advertised on television. And so they call them one thing and we call them something else, but anyhow. All right, so the thrust of our talk tonight revolves around immune-related adverse events, which are called IRAEs. That term is used essentially interchangeably with IMARs, or immune-mediated adverse reactions. All of these terms are just to say this is what happens when the immune system starts attacking parts of the body that are not the cancer, normal parts of the body. These are toxicities associated with immune checkpoint inhibitors when they are either administered alone or with other therapies. So let's watch another brief video about that.
This animation illustrates the unique spectrum of immune-related adverse effects associated with immune checkpoint inhibitors. Immunotherapy, such as checkpoint inhibition, enhances the ability of the immune system to recognize cancer cells, leading to the anti-tumor responses and cancer cell death. The enhanced immune activity with immunotherapy is associated with autoimmune responses known as immune-related adverse effects. Immune-related adverse effects can affect a range of organ systems, including the nervous system, cardiovascular, pulmonary, gastrointestinal, musculoskeletal, ocular, endocrine, dermatologic, hematologic, and renal systems. It is important that patients, caregivers, and healthcare professionals remain vigilant during and after immunotherapy to ensure timely recognition and management of immune-related adverse effects, so that patients derive maximum benefit from these therapies.
So the any organ system message is really an important one, and we impress this upon patients essentially at every visit, which is to say that if you, the patient, notice a change in symptoms, something is different from baseline, something just does not feel right, don't assume that whatever you are feeling could not be an adverse effect of the medication. It very well could be. It really could attack any organ system. It's the immune system, as I said, that's doing the heavy lifting. The immune system circulates throughout the body, and so any tissue essentially is at risk. And so we involve a lot of subspecialty colleagues in complex cases because, as you can see by this long list of possible IRAEs, these can get pretty involved. So the job of an emergency medicine physician is to understand when one of these might be taking place and to start initial therapy to stabilize somebody who might be experiencing an IRAE. So patients ask, well, what should my presenting symptoms be? What am I looking for? And the question, of course, for the practitioners in this room is, what should we be looking for? What should concern me when a patient walks in the door that, in fact, they might be experiencing an IMAR, an IRAE? Well, it depends on what part of the body is hit by the immune system, what part of the body the immune system attacks. If the immune system attacks the colon, you might get an inflammation of the colon, a colitis, and get diarrhea. Same thing is true with lung inflammation. You might get a pneumonitis and therefore develop cough or shortness of breath. If the pituitary is attacked, patients develop hypophysitis and they develop a headache or fatigue, profound fatigue. Same thing is true with the skin, bad dermatitis, they get a rash, myocarditis, and the list goes on and on and on. Patients also ask, so when should I expect this to occur? The kinetics of these medications are not like chemotherapy, where we could tell you with some predictability it's going to be 7 days or 10 days or 14 days. Your blood counts are going to nadir and then they're going to come back up. That is not true with immune checkpoint blockade. I've seen adverse events occur with immune checkpoint blockers the first night of therapy. I've also seen them occur a year after the last dose of therapy. They can occur anytime during or after therapy has stopped. The delay, the possible delay of occurrence of the IRAEs is really important because patients don't think 6 months down the line, oh, this terrible arthritis that's crippling me now could be associated with this drug that I last had 6 months ago. But it's our job to think about that. So how do we treat these in general? So we think of immune-related adverse events in 3 categories based on their severity. Grade 1 is mild. And so generally these patients require supportive care. So this would be somebody who has, for example, a rash over less than 10% of their body surface area, or diarrhea 1 time a day with no blood or real abdominal pain, sort of thing. Grade 2 generally requires low-dose corticosteroid as first-line therapy. And so by low dose we mean prednisone or equivalent, dosed to 0.5 to 1 milligram per kilogram per day. So in an 80-kilogram patient, that is between 40 and 80 milligrams per day of prednisone or the equivalent. And then grade 3-4, or severe side effects, and these are sort of ones that you know them when you see them. 9 episodes of diarrhea over the course of a day with blood in the stool and terrible abdominal pain, sort of thing. So these patients require high-dose corticosteroids, 1 milligram per kilogram, perhaps 2 per day, tapered slowly over a month. This slow taper is something that's very important. We have had a couple of disasters where patients have been sent out with a 5-day Medrol dose pack, and then the toxicity comes right back at you. We don't taper steroids that way in this setting. We generally do them over at least 4 weeks. So you will be handing off these patients to somebody else who will do that tapering, but this is important for you to know. If somebody comes into your ER having tapered steroids over 5 days and they're wondering why their toxicity came back, you can tell them, well, your steroid should have been tapered over a month and you can restart.
Now tell me, is that grading? Is that an oncology grading system? Is that from, I see that a lot in clinical trials, like when you're grading adverse events to submit them.
It is. So officially this comes from the common toxicity criteria that's officially called the CTCAE, which is available online. It's published by the National Cancer Institute, and it just normalizes how we grade a particular toxicity. So a dermatitis that's less than 10% of body surface area gets a number 1, a grade 1, and then up the line. That's not so important for us in the emergency department setting. We need more of a gestalt about how this is impacting the patient, and you can kind of base your recommendations for therapy on how mild, moderate, or severe you think the symptoms are. All right, so what are the takeaways from what we've discussed so far? So the immune checkpoint inhibitor class of cancer immunotherapies blocks T-cell inhibitory signals. So the T-cell is given an inhibitory signal by the cancer. We are blocking that signal. In doing so, sometimes we are allowing T-cells to attack normal parts of the body. As Andrew said a moment ago, the landscape is expanding rapidly. Patients are now coming in having had different therapies than before. This is no longer just cytotoxic. Now we're dealing with immune therapies. That differs from other cancer therapies because toxicities are inflammatory in nature. Any organ system of the body could potentially be impacted. They can occur at any time, including after the first dose, or months, or perhaps a year after the last dose of immunotherapy. And in general, in the emergency department setting, corticosteroids are first-line immunosuppressive therapy for most patients that experience IRAEs.
All right, so we've seen the basic science here. We've talked about mechanisms. Now we're going to go through some clinical cases. So this is exciting. We've told you all the reasons to be scared, and now we're going to give you a message of hope and show you all the things you can do and how you're going to be able to recognize these readily in your everyday practice. So first case, right. Woman aged 60 years with kidney cancer presents with 3 days of profound fatigue. She also has a headache that's not getting better with medications that she's taking at home. Otherwise, negative review of systems. So you don't have to send this one in. Just a show of hands. Who saw somebody with extreme fatigue the last time they worked clinically, right? Right, yeah. So we see a lot of these people, right? And so it can be overwhelming. No, she's been on antidepressant for a year. No other medications that we're able to elicit. So next step, get a cancer treatment history. I'm sure you know where this is going, right? So we find out that she was treated with combination checkpoint inhibitor therapy. She had gotten nivolumab and ipilimumab 4 months ago. So now, because you're all here, you're all here, your antennae go up. We see physical exam, afebrile, a little tachycardic, a little hypotensive, a little tachypnic. So we know something not good's going on. Oxygen saturation's normal. Just appears a little depressed and anxious. She has this mild headache. She's orthostatic, but the physical examination otherwise isn't giving you much. So we order a bunch of labs. Maybe we start some fluids and we see our other patients. Then we come back when our labs and our imaging comes back. And what do we see here? And I know, this combination of a low sodium and a high potassium screams out to a lot of us, right? That there might be some element of adrenal insufficiency going on, right? When we see this right here, in combination, she's got a negative head CT, and we remember from this presentation that is one of the possible complications. So we still have a broad differential, right? We haven't ruled anything in or out quite yet. We're still thinking, somebody who's depressed. Well, probably not, because she's got vital sign abnormalities. She's hypotensive. She's tachycardic. She's a little tachypnic. Brain mets, possibly one that's going to show up on MRI later. We don't see anything moving things around on CT scan. But right, with those lab findings and that hypotension, is this immune-mediated hypophysitis, pituitary inflammation? Is this immune-mediated adrenal insufficiency? Right, and those are things that we're going to need to think about. So what do we do, right? So depending on what resources we have available, we can do more of these things. So one, we all know to hospitalize this patient, right? She's got vital sign abnormalities. She's got this concerning history. We can send cortisol and ACTH levels. They might not come back when we're working. It's going to help the next doctor. Same with pituitary hormone levels. We can get the oncology provider on the phone because they will be more familiar with these adverse effects. they're going to be more familiar and more able to tell you when this patient started these medications, and they'll know a little bit more about their disease. How's this person been progressing? Have they showed up to the other hospital across town with the same thing a couple weeks ago? Okay, so we'll get lots of useful information there, and help us facilitate our admission. And this is going to be a common theme. We're going to start steroids. So we're going to, in this case, prednisone 1 milligram per kilogram per day is a solid dose. We're going to get this person in the hospital, and we're going to be able to move on. So again, we're taking a patient with just a really standard chief complaint that we see every day, and by eliciting the presence of these drugs in the history, you recognize that there's going to be a very specific step that you're going to need to take in managing them. That's to get them steroids. All right.
Just one comment about the adrenal insufficiency. So typically when patients have a headache that is unresponsive to over-the-counter analgesics, in somebody who has received immune checkpoint blocking therapy, we think about hypophysitis as the first thing on the differential. As we'll show you a little bit later, various parts of the brain and the linings of the brain can be impacted. And so you have to cast a wide net in terms of what parts of the central nervous system are being impacted. Having said that, in the emergency department setting, giving a patient like this corticosteroids is almost never a wrong first move. And so the key takeaway in a lot of these is to think about the possibility that it's related to the drugs and treat the patient as we mentioned. I will say that in cases of hypophysitis, these patients turn around very rapidly. So this patient that comes in with a very low sodium, feeling depressed and anxious with a bad headache, in general, within 12 hours of giving somebody a slug of methylprednisolone, they're feeling like $1 million. It's that quick.
So you mentioned a lot of these hypophysitis patients having headache and presenting. Are they presenting first with the headache before they're having these other findings?
It's a good question. It's variable. I'll tell you two stories. So we took care of a couple of gentlemen a few years ago. They both at some point developed hypophysitis and adrenal insufficiency. One of them presented just as we talked about here. So headache, took acetaminophen, took ibuprofen, wasn't getting any better. We sent him to the ER. The local ED physician called me. I said, check a serum cortisol. It was undetectable. We started him on steroids. Fixed. The second guy presented very differently. This gentleman was in his 70s. He was a retired salesman. He's a very gregarious guy. He's the sort of guy who would walk into a room and light up the party as soon as he walked in. He came into the clinic that day depressed, no energy. He didn't greet us the way that we were used to having him greet us. His wife said he's in bed a lot of the day. It just was not him. And that was his presentation of hypophysitis, and he had no headache. He was just not himself. Good question.
Yeah. For our second case, a 62-year-old man with lung cancer presents with a rash. And I could ask the same question, how many of you saw a rash like the last time we worked, right? And we'd all raise our hands, right? Rashes are also a dime a dozen in the emergency department. This fellow, it's a pretty significant rash. It's more than 30% body surface area, and there's blister formation. So again, we're thinking of common scary things like cellulitis, and we're also thinking of drug hypersensitivity reaction. Because we're here and we learned about these immune-mediated adverse events, we know that this could be a complication of immunotherapy. And for mild patients, the treatment for dermatitis may be as simple as a topical steroid cream, like something low or moderate potency. For more severe patients, they're going to need systemic steroids, and certainly this patient falls into that category with 30% body surface area involvement. But what are we going to do, right? We're going to admit the patient to the hospital. We're going to start steroids, systemic steroids, whether that's oral or IV. We're going to talk to their oncology provider, and then hopefully, and then after admission, a dermatologist or someone can get involved and to confirm a tissue diagnosis especially if they're not getting better right away with that immediate therapy. But for us, what we have to know is we have to recognize that this immune-mediated adverse effect is a possibility so that we can get the steroids going and get them in the hospital. And some of these patients have even been known to have TEN or Stevens-Johnson. So it's rare, but it's something that can occur. And so they're going to be told, from their oncologist to be on the lookout, for mucous membrane involvement and skin sloughing. But anybody that you're sending home, you want to impress. So some of those mild patients that just need topical steroids, you want to impress on them these return precautions, right? If you see the rash getting bigger, if you see mucous membrane involvement, if you see sloughing of the skin, that would definitely be something for that patient to come back.
There's a good question that just came in that's asking about whether immunosuppression with steroids might reverse the anti-cancer activity of the medications or cause a cancer flare. And that's a great question, and one that we get from patients not infrequently. And you're right, it does feel like we're sort of pulling at both ends of the same rope, right? On one hand, we're asking the immune system to activate and go kill cancer, and on the other side, we're giving prednisone and asking it to back off. The good news is that the studies that have been done thus far in thousands of patients demonstrate that after an immune-related anti-tumor effect has taken place, in other words, after the immune system has begun attacking the cancer, you don't reverse that by giving corticosteroids in this setting. And so we can reassure patients that come in with a toxicity that require corticosteroid administration. You're not going to allow your cancer to grow by giving the corticosteroids. Now, the same is not true if you give patients corticosteroids right from the get-go. If you give dose 1 of immunotherapy along with dose 1 of prednisone before the immune system has had a chance to sort of ramp up the anti-tumor response, there you are, studies show you are in fact blunting the anti-tumor effect. But we do not hesitate, especially in serious cases like this one, where a patient's tumor has already been attacked by the immune system, to give corticosteroids. Something else that will not surprise you is that there is an association between response to tumor and side effects to immune checkpoint blocking therapy, which makes perfect sense, right? Because if you have activated the immune system to go and attack whatever, it manifests as both killing cancer and attacking the rest of the body. And so patients that have had immune-related adverse events are more likely to have good anti-tumor responses, more likely to have regressions of their tumors.
Yeah, somebody made a great point about the first case, potentially being sepsis, and that's absolutely right. We could have that in our differential also. If you remember, that was the our adrenal insufficiency patient that was a little hypotensive, a little tachycardic. I know that I work with Epic, and all of our alarms would start ringing. That patient would probably empirically get antibiotics, but remember, there's just more reason to broaden our differential and not only think about sepsis. And it's not the wrong answer to give the broad spectrum antibiotics, but also give this patient steroids and recognize the potential diagnosis for adrenal insufficiency.
Yeah, I'd like to just underline that. There's another question that asks, how do you know months out that it is an IRAE and not something infectious or caused by something run-of-the-mill in the ED? You don't, and that's why with all of these cases, we're presenting you with a broad differential, because even 6 months out after therapy is stopped, you have to keep all of those in mind. So absolutely, work up for sepsis at the same time that you're thinking about adrenal insufficiency from checkpoint blocking therapy.
All right, so our third case, 45-year-old woman with melanoma, presents with fatigue, dizziness, and thirst. She began her Pembro 3 months ago. Now, this should be a presentation that we'll all recognize. We've probably seen 1,000 different variations of DKA and new onset diabetes, but it's something that we need to be on the lookout for people that are taking these immunomodulators, right? So we see that here, right? The hyperglycemia, the acidemia, and this case is, let's go on to our next slide. It's a little bit of our curveball, because this is the one time where we're not recommending steroids. And the way I understand it is that in this case, the islet cells, they've already been attacked, they're already damaged, they're gone, right? And this patient is a diabetic, and the steroids aren't going to reverse that process. They're only going to make glycemic control that much harder, right? Because that's what glucocorticoids do. So this one is kind of the exception to the rule that we're going to teach today. But otherwise, it's just standard management for DKA. But when we see these patients, to recognize that diabetes is a potential problem, and new onset diabetes is something that we can see.
So this is a good point to talk about endocrine versus exocrine pancreas attack. In an individual patient, prior to starting therapy, it is almost impossible to tell what part of the body is going to be attacked. So it's important to keep patients informed that whatever symptom they might encounter, that they should report those symptoms to us quite promptly. Exocrine pancreatitis is one that is particularly tricky because patients have this non-specific abdominal discomfort that they tend to sort of brush off and just think, well, it's something I ate, and this can go on for days and days and days. I'm treating a patient right now who himself is an emergency physician with immune checkpoint blocking therapy. I don't know that he's heard my lecture, but he's been doing this for quite some time. It did not dawn on him to call me to tell me that he was having what we recently discovered was immune-mediated exocrine pancreatitis with amylase and lipase in the thousands. So I only caution you because patients that come in with this non-specific abdominal pain often present with exocrine pancreatitis. And in those cases, corticosteroids is quite helpful. And we see that you can bring amylase and lipase levels down very quickly within 48 to 72 hours, and patients feel much, much better. The trick is that oftentimes patients sort of blow this off because it's non-specific, and patients have belly pain all the time, and it just doesn't get reported quickly. So be on the lookout.
All right, so our fourth case, a 77-year-old man with a history of lung cancer, presents with trouble breathing. Sinus congestion, was started on antibiotic a week ago from an urgent care center. Typical symptoms that we see all the time: cough, shortness of breath, chest tightness. Patient is already on warfarin because of their history of DVT, albuterol, and we see that they're taking atezolizumab. Vital signs: 99.9, that perfect temperature that can be anything we want it to be, or everything that we're afraid that it could be. It's either just a normal person wrapped in an extra blanket, or it's a fever, right? A heart rate of 102, like just that perfect, just a little bit of tachycardia that somebody might either wish away, or it could be a harbinger of something really scary. Blood pressure, essentially normal. Low oxygen saturation. Tachypnea, and we hear bibasilar arousal. So chest x-ray shows these infiltrates, shows an effusion. Patient's anemic, but otherwise unremarkable labs. So the differential here is huge, right? We see these patients a lot, and so we think about pneumonia. We think about worsening of their lung cancer. Is it lymphangitic disease spread? We think about PEs, right? This person, sure, they're on warfarin, but it's not uncommon for somebody on warfarin to get a PE through that. And finally, immune-mediated pneumonitis is the thing that we're adding to our differential today. And I just saw this a couple weeks ago with a patient on pembrolizumab. So this is something that I'm already seeing. It's affecting my practice. So what do we do? Get the oncologist, on the phone, see if we can get any more information. Oxygen, CT of the chest. CT shows these findings, shows these ground glass opacities, shows the effusion that we saw already. Here's just some more pictures of that.
I'd be interested. We can go back one
yeah,
slide.
sorry.
So I'd be interested as you guys look at these films here. These are all from the same patient, by the way. If you look at the panel on the left side, what comes to mind? You can just call it out. What comes to mind as you look at that left-sided panel with those small areas? What diagnoses sort of spring to mind? Yeah, those sort of look like lung metastases, right? Those could well be tumors that are growing, especially in the setting of lung cancer. What else do you think about? What's that? Sarcoid? Yeah, that's right. Sarcoid could certainly look like that, especially in a patient where you don't have another baseline to compare it to. You know, the patient's being cared for at another hospital. You can't see the images from outside, and this is the first time you're seeing the patient for sure. How about the middle panel? What do you guys think about? There's a microphone wandering around the room. What do you guys think about when you see the image displayed on the middle panel there? What comes to mind? How about a bad atypical pneumonia? Could be consistent with that, right? Some air bronchograms in there, right? And then what about the panel on the right? Infarction, yeah, that wedge-shaped thing looks like an infarcted lung, yeah. So I'm putting these up here to make the point that checkpoint inhibitor-associated pneumonitis is highly variable in its radiographic presentation. And some of the things that we just discussed in this room are what were running through my head when I looked at these films initially. But it turns out that we bronched this woman and pulled out tissue from all of these areas, and they were all consistent with immune-mediated pneumonitis. And not only that, they all responded to corticosteroids. And so I just put these up there to make the point that you can't assume that it isn't pneumonitis just by its radiographic presentation. It can almost look like anything, which makes things even more confusing.
Yeah. All right, so we're not going to get that tissue diagnosis, you know, in our practice setting, right? But at that moment, we can start steroids, we can give antibiotics, get the patient in the hospital, and let all that stuff happen. And really, you know, the step that's probably outside of our current practice pattern, you know, before today, are really the steroids, right? I think we're all giving antibiotics. We're all bringing this hypoxic patient with a scary CT scan into the hospital. But now we know we want to start corticosteroids as well. Yeah.
So this is a good time to talk about infections in cancer patients. And this is a question that comes up from the patients themselves quite frequently.
And somebody actually asked, I think, about infective processes. And
yeah, it's a good question. So the first question about infections that patients ask is, when I'm on these therapies, is it okay for me to visit my grandkids? Can I be around people who are sick? Am I at greater risk for contracting infections than I am right now? And if this were cytotoxic chemotherapy and we were going to make somebody neutropenic in 10 days, we would say, yeah, you really have to be careful about, you know, washing your hands and wearing a mask in public and things like that. But these drugs don't work like that. These patients are not at risk for run-of-the-mill infections the way that patients on cytotoxic chemotherapy might be. However, there are a couple of important things to keep in mind. One is that the anti-PD-1 drugs and PD-L1 drugs and what have you, the immune checkpoint blockers don't provide any protection against other bugs that, you know, people are at risk for. So do we tell our cancer patients getting immune checkpoint therapies to get an influenza vaccine every year? Absolutely. Should they get the rest of the vaccinations that are recommended by their primary care physicians? Absolutely. Are we concerned about whether they are able to mount an immune response to getting those vaccinations? We are not. The cytotoxic chemotherapies will dampen T-cell responses in ways that the immune checkpoint blockers do not. So we encourage all of our patients to get their appropriate vaccinations. Pneumocystis pneumonia is something that should be on everybody's radar, not in patients that have had immune checkpoint blocking therapy alone, but rather in patients that have had immune checkpoint blocking therapy and then have required corticosteroids to treat a toxicity for immune checkpoint blocking therapy. The National Cancer Comprehensive Network recommends that any patient who needs high-dose corticosteroids, meaning 20 milligrams of prednisone per day or more, for 4 weeks or longer, you should consider using prophylaxis for pneumocystis. Not everybody receives that. And so if a patient comes into you and presents with pulmonary infiltrates, it's important to keep in mind that these patients may have had corticosteroids from another provider to treat a toxicity of immune checkpoint blockade, which then puts them at risk for pneumocystis and other things. Let's see.
Yeah, I have one question. Let me know if there's a right answer to this. This is based on somebody. So somebody asked, if somebody's a few months out, how do you know if it's run-of-the-mill basic ED stuff or if it's one of these immune-mediated adverse effects? And I'll give you just let's get an example. Let's say somebody stopped Pembro 5 months ago or 4 months ago, and they have a cough, and we see a tiny little pneumonia on chest X-ray, the kind of thing that I would send home. I'd give them antibiotics and send them. Am I now giving them, calling you? Am I giving them antibiotics and steroids and sending them home, or am I keeping them, or how should I approach that?
It's a good question. So I'll say one thing about pneumonitis before I directly answer the question. Yeah. Pneumonitis can get very serious very quickly. On the first large phase 1 trial of one of these medications, it's about 300 patients. We had 3 patients die of pneumonitis. Sometimes even if you get on top of the pneumonitis symptoms very quickly, within 24 hours, you still cannot turn the immune system attack around. And so I just urge you to be extra cautious in patients who present with something that you think might possibly be checkpoint-related pneumonitis. Okay, so the question is, how do you figure out sort of in a patient who's got, a 4-month history of having been off drug, who now comes in with a little bit of an infiltrate on the chest X-ray or on a CT scan, what's what? So in general with pneumonitis, we try to be cautious, try to be conservative. And if a patient has presented to you because they have symptoms, they have an ongoing cough, there's something that's actively going on, and as a result of the symptom that they have reported, you have done chest films to then find, this infiltrate, I think it's worth treating them probably with both steroids and antibiotics, and then contacting the oncologist for a further workup, or pulmonology for a further workup as an outpatient. Conversely, if the patient comes into you with some other unrelated symptom and you happen to check a chest X-ray or a CT and find an asymptomatic inflammatory looking something on a chest film someplace, that I'm less concerned about treating with corticosteroids off the bat.
It's always the test that you don't know why it was ordered that,
right,
for me, that gets me into the most right, trouble.
Exactly.
The test that somebody in triage ordered that doesn't correspond to any of the patient's actual symptoms and has some vague finding, and now I'm stuck to sort through it. So we'll move on. We got a 72-year-old woman with lymphoma with an upset stomach, nausea, crampy pain, increased flatus, diarrhea. She's on an ACE inhibitor and a thiazide diuretic. She takes oxycodone, takes Senna. She's on ipilimumab and nivolumab, and she has this chronic pain and hypertension. So somebody that might look like a lot of our oncology patients. Temp is 99.1. The heart rate is high normal. Blood pressure 110/64. Her exam, she's got this moderate diffuse abdominal tenderness. She's not peritoneal. She's not rebound or guarding. Hyperactive bowel sounds, but bad enough that we want to scan her, especially considering her history. So we get that scan, and we see colonic thickening, pericolonic stranding, so consistent with some kind of colitis. And her white count's a little bit elevated. She's a little hyponatremic, a little hyperkalemic, so her labs don't look perfect, but otherwise unremarkable. So we got this woman with this colitis. Her labs are a little bit affected. Her electrolytes are a little bit affected. So what are we thinking about? Could it just be viral gastroenteritis like all of our other patients, of course? Could it be C. diff? Certainly, a lot of these patients have been on antibiotics at different points during their therapy. Could it be another drug that she's taking that's causing this? Could it be intestinal effects of her cancer? Yeah. And finally, right, we showed you that slide in the beginning where it showed these drugs potentially attacking anywhere. This could be immune-mediated colitis. So, we're going to get the stool studies. We're going to check for C. diff, get a stool culture. A lot of that stuff I know in my department isn't going to be available right away. But what we can do right away is start steroids. We can talk to the oncologist and do our supportive care to get this person taken care of. We're going to admit this patient to the hospital, and a key point here is for in most cases the bioavailability of steroids, PO and IV, is pretty similar. In this case, remember these patients, because they have diarrhea, these are definitely people, or they have impaired intestinal mucosa. These are definitely people we want to give it IV. We want to make sure that we're giving them steroids that they can absorb and that they can use.
So 2 quick points on this patient. So one is that the transition from intravenous to oral corticosteroids is something that often trips us up, even in the inpatient oncology setting. And so somebody will present with this story, and we'll get them on intravenous methylprednisolone, and things are going along just fine. We're 24 hours in or 48 hours in, and the symptoms are resolving, patient's feeling better, labs are improving, diarrhea's gone, essentially. And then we'll stop the intravenous steroid and discharge the patient on an oral taper with the appropriate length, 4 weeks of a taper. And lo and behold, they wind up back in the ER within 24 hours because the transition from intravenous to oral did not go smoothly. They still cannot absorb the oral corticosteroid that you're giving them. So what we try to tell the hospitalist teams is that you need to keep these patients in-house for a day on oral corticosteroids before you discharge them. And I would tell you that in the ER as well for patients that are held in your emergency department for 23 hours or what have you. 1 dose or 2 doses on IV corticosteroids does not guarantee that the patient's going to fly on orals if you discharge them like that. Just keep that in mind. And the second is, there's a good question here that says, how long on steroid before you can judge whether the patient's condition is not improving and you need to start infliximab? All right, so infliximab is a drug that is a tumor necrosis factor blocker. It's a TNF-alpha blocker. And it's a medication that we use as first-line therapy in patients that have immune-related colitis that is refractory to corticosteroids in one of 2 ways. So let me describe each of those. The first way is that you give somebody corticosteroids, high-dose intravenous corticosteroids for immune-related diarrhea, and you're using the correct dose, 1 or 2 milligrams per kilogram per day, and the symptoms are not getting any better. And you usually know that within about 48 hours. If at the 48-hour mark things are not turning around, something's wrong. This is a steroid refractory case. That's the first kind of steroid refractory. The second kind of steroid refractory is somebody who does well on corticosteroids, and as you are coming down on your taper, they hit some sort of cliff, and going from 50 milligrams a day to 40 milligrams a day brings the diarrhea right back again. We see this not uncommonly. Those patients are steroid refractory in a different way, and those patients oftentimes need either to go back up to the level where the corticosteroids were effective and then to slow down the taper, or in some cases, in those patients, we use infliximab when they fall off that cliff. So this is not something that comes up in the ER very frequently. But I will say, if somebody has been started on corticosteroids someplace else and winds up in the ER and is clearly a steroid refractory case, it is not unreasonable to at least admit them to the hospital and communicate with the hospitalist that you think this is a case that probably requires infliximab. I don't imagine that many emergency departments use infliximab in the ER. I don't think ours does.
Not routinely.
Certainly not commonly, yeah.
One of you guys tell us to.
Right, but something to keep in mind.
So are diagnostic tests needed before starting steroids? No, not necessarily, right? As you see in a lot of these cases, we're giving them empirically. And we're going to start right away. So if there's this possibility of colitis in addition to the typical stuff that we're doing, we're giving the steroids also. And what about the role for budesonide for mild diarrhea?
Yeah. It's a good question. So there are some patients where prednisone is just really intolerable. So we have patients, for example, with a psychiatric diagnosis where we know that high-dose corticosteroids are going to throw them into mania. Or we know that we have patients with poorly controlled or brittle diabetes where high-dose corticosteroids is really going to throw their sugar out of whack. And so for patients who have some contraindication to high-dose corticosteroids, budesonide is an option. It's a steroid that is retained within the GI tract and doesn't really get much absorbed beyond that. And so for patients with, say, a grade 2 colitis, where things aren't severe, oftentimes we can get away with using budesonide. The dose is 9 milligrams per day, and that's given as a slow taper, just like prednisone is. But this is something to consider if a patient is really not a candidate for oral corticosteroids as we typically think of them.
Case 6. So a 78-year-old man with squamous cell skin cancer has a headache and altered mental status. So headache, fever, confusion, neck stiffness, so red flags all over the place. The patient's on aspirin, diltiazem, benazepril. Patient has a history of radiation therapy to the skull for the skin cancer, history of hypertension, atrial fibrillation, and they're on cemiplimab. All right, so essentially a low-grade fever. Vitals otherwise look stable. Lethargic, alert, oriented, confused. Generally weak, but non-focal neuro exam. So what are we thinking? So of course we're thinking about sepsis. Of course we're thinking about meningoencephalitis. Immune-mediated encephalitis is now on our differential as well. So do we have to treat, the question earlier, do we have to treat sepsis? Yeah, so we're giving them antibiotics. Do we have to figure out if they have meningitis? Absolutely, we're going to do a lumbar puncture. Probably going to look for other sources of infection if we don't find anything on the lumbar puncture, so chest x-ray, urinalysis. We want to get the oncologist involved to learn more about the patient and to make sure that we're giving them the best corticosteroid therapy and getting them to the best place. And ultimately, these people are going to need an MRI as well, after they're in the hospital. So in this case, the lumbar puncture shows elevated lymphocytes, negative gram stain, this slightly elevated glucose and protein. So it's kind of positive, but not screaming bacterial meningitis, not screaming Neisseria meningitis. This is kind of aseptic meningitis picture. The MRI shows unilateral temporal enhancement, if you have the benefit of seeing that. So this is a case of immune-mediated encephalitis. There's a wide variation in presentation, wide variation in clinical presentation. People can occasionally just be altered mental status, right? People can also present with headache and neck stiffness, more of a meningitis type picture. But the CSF will hopefully show these inflammatory findings, and ultimately diagnosis can be confirmed with MRI. This is a patient who's not going to tolerate PO steroids, so we're going to give them methylprednisolone. We're also covering meningitis with antibacterials and antivirals. Of course, we're hospitalizing, or maybe even the intensive care unit, depending on where these lumbar puncture, altered mental status patients in your hospital go.
So I think this is a good time to address one of the issues that was brought up in a question, and then also talk about maybe cardiac toxicities. And the reason those are tied together is because these are some of the more serious and life-threatening and possibly difficult to manage situations that we run up against. So the question that I want to address involves discussing what to do with remote hospitals. So critical care for patients that are being treated at rural hospitals or places where you don't have access to a tertiary care center. So I think about it in a couple of ways. So the first is that there are cases where right from the get-go that this is really something that's going to require some subspecialty care. So this is probably one of those cases. An immune-mediated encephalitis where you can see findings on MRI that, I think, is probably worth at least a phone call to certainly the patient's oncologist, but possibly one of the tertiary referral centers that has a neurologist on staff who can, help talk everybody through what needs to happen. The second is the cardiac toxicities. Has anybody, just show of hands, anybody seen a cardiac toxicity? You have. What was the outcome of the patient? We never hear. You never hear, okay. That's common, that the information does not get relayed back to the emergency physician staff. Unfortunately, we try to be better about that. The outcomes for patients who have immune-mediated myocarditis or cardiac toxicities is that in about 50% of cases they die of that toxicity. So it's a very serious toxicity. So with encephalitis, with myocarditis, with a toxicity that is extraordinarily complex or that has an extraordinarily high fatality rate, I would encourage everybody to reach out to a tertiary center, either to request a transfer, ED to ED transfer, or to at least talk with a subspecialist at the center to talk through what needs to happen next. I know that's not an ideal answer, and it would be great if we all had resources at our hands in the place that we're caring for our patients, but some of these are just overly complex. Okay. There was one other question that related to this here.
Yeah, somebody asked about herpes encephalitis for this case. Yeah, absolutely right. We would think about that, and I think that's why we'd have the antivirals, going. This is somebody that we would give acyclovir to.
Yeah. The related question was, critical access hospitals probably don't have emergency MRI access. I wonder if you can just speak to what that means in terms of management.
Yeah. So the MRI, I know that most of us can't get an MRI on an emergent basis, and probably most of us don't want to be able to get an MRI on an emergent basis, right? Where, it would keep a lot of patients in the department that we already know they need to be admitted and they can wait for their MRI. If you don't have MRI access, these are still people that we should be able to recognize. Either they're confused, they had a positive LP, there's something else about them that is signaling the chance of this encephalitis, that we can start steroid therapy right away and then getting them to a spot, whether they need to be transferred to a place ultimately to get that MRI, to make the definitive diagnosis. But it's more important emergently for us to recognize the possibility and to start the steroids than to make the actual diagnosis right away. And somebody asked about dexamethasone here. It's interesting. I know where I work, neurosurgeons, it's always the steroid that they use, dexamethasone. So they're always recommending that. And I know that dexamethasone, compared to for example methylprednisolone, is more glucocorticoid and less mineralocorticoid. And I don't know if there's something else about it in the head. Whether it's more bioavailable or it's more CNS penetration, or whether it's just part of the culture of neurosurgery and it's just something they like because it's something they like. Do you know for things in the head or things in the brain, is there any advantage to dexamethasone over?
Yeah, we haven't seen a difference. Patients who need steroid coverage at high doses, whether somebody gets dex or methylpred or what have you, it doesn't really seem to matter. Why don't we did you have something else you wanted to address? Why don't we go through some of these questions and then we'll do our last case. So let's talk about this one here. So, what is the best way to distinguish between pulmonary embolism, worsening of lung cancer, and immune-related toxicity in a patient presenting to the ED with acute shortness of breath? This is really challenging. In the ED setting, in that case, unfortunately, we often end up shooting first and asking questions later, because the interventions that are often required to differentiate between those items on the differential and probably more really need to happen in the inpatient setting. So for example, a patient who walks in the door with a history of lung cancer, who has a CT scan like the ones that we showed you before, where on your differential is a COPD exacerbation an infectious problem, and an immune-related pneumonitis, we generally treat them with antibiotics and corticosteroids, get them admitted, try to get them bronched with a biopsy of the lung parenchyma. And if we're fortunate enough to figure out what is or is not growing in the lung, we pull back the medication that we don't need. So a negative bronch and the BAL is stone cold negative with no infection. We pull back the antibiotics and keep the corticosteroids going, and the reverse is also true. Unfortunately, this is not something that we can generally sort out in the ED setting. There just isn't enough, time and resource at that point. So what I encourage ED providers to do is to sort of treat empirically for what you think might be going on, hospitalize the patient, call the oncologist, talk to the hospitalist about what you think might be on your differential, and they can go from there.
Yeah, somebody else had a general question that what percentage of patients on checkpoint inhibitors are getting these? Because I know we're probably by the end of this presentation, you're wondering why anybody would ever want to be on these medications.
Right. Okay. This is a great question. What percent of patients on checkpoint inhibitors get adverse events? The answer is it depends on which checkpoint inhibitor you use and in what combination. So if you use just a standard run-of-the-mill anti-PD-1 or anti-PD-L1 drug, typically about 15% of patients get a serious toxicity. And by serious, I mean something that we have to intervene upon, something that might show up in your ER as something that's an urgent need for therapy. Now, having said that, 80% or so of patients wind up with some toxicity, but it's generally mild. And so folks a lot of times sort of skate through their course of therapy without too much in the way of toxicity. And because that's the large majority of people, patients typically are excited to begin this course of potentially effective therapy where there has not been an effective therapy before. What do I mean by effective? Let's talk for a second about metastatic melanoma, which is a disease that I treat. 10 years ago, the survival rates for patients with stage 4 melanoma were about a median or so of about 9 months. These days, if you look at the last publication in the New England Journal looking at the combination of ipilimumab plus nivolumab, 52% of patients at 5 years were alive. That is a huge jump, right, in the world of metastatic melanoma. Melanoma, as they say, is the cancer that gave cancer a bad name, right? It's a very difficult cancer to treat. And so why are patients willing to get on these therapies and experience these toxicities? Because the potential for benefit is huge in some cases. Now remember I told you that it depends on how many immune checkpoint therapies you're using in a particular patient. So the numbers I gave you a moment ago are true for a single agent PD-1, PD-L1 drug. 15% or so of patients get a toxicity that's serious. When you start combining agents, ipilimumab plus nivolumab, then the rates jump up to 55, 60% of patients get a serious toxicity. So the more agents you use, at least the ones that are now approved, the more toxicity rates rise. There's a good question here about the duration of therapy. So how long do patients need to be treated with immune checkpoint blocking therapies? That's a great question. Unfortunately, we don't have a good answer for that for an individual patient. There are some people that clearly need just a little bit of immunotherapy. I have a patient with melanoma, metastatic melanoma, a very large 15 centimeter liver tumor, who came to us back in 2015. He got a single dose of ipilimumab plus nivolumab, which is approved for metastatic melanoma. 1 dose of each drug. That was it. He wound up with immune-mediated pneumonitis and colitis and dermatitis. He had a long list of itises, long list of IMARs, and required corticosteroids for weeks, and he required, I think, 4 doses of infliximab over time. He has never gotten another dose of ipilimumab or nivolumab, and that liver tumor continues to shrink after just a single dose of both drugs 4 years ago. He only needed a single dose. Conversely, we have patients that really haven't gotten much in the way of side effects. They still have what we think is visible disease on CT scan. We're 3 years in, they're doing great, and it sort of seems, well, to stop the therapy might be risky, and so we continue. So we just don't know what the duration of therapy is what's necessary for each individual patient.
Somebody asked about D-dimer. Do you know if they affect the D-dimer? I don't know.
That's a good question. I'm not sure if they do.
Yeah.
Yeah, the D-dimer question is a good one. I don't know. And then the procalcitonin question is a good one too. So procalcitonin, I don't know how if you use it in the ER, but so procalcitonin levels in various studies have been used as a marker for not needing antibiotics. It guides antibiotic therapy. I don't actually know if it's been tested in patients that are getting immune checkpoint blocking therapies. Anyone seen that? I'm not aware of any literature that's out there about that. Okay. Next question. Are there PD-L1 markers on normal cells? All right, so this is a terrific basic science question. So remember that slide that I showed you with the T cell on one side and the tumor cell on the other, and in between there's these two red molecules, two red bar molecules. PD-1 is one side of that equation, and PD-L1 is the other side of that equation. And when those two meet up, it's a signal to the T cell to back off and not attack. So do normal tissues contain PD-L1? Do normal tissues have that signal that says back off and not attack? Yes, absolutely. That is one way that normal tissues signal the immune system to not attack. Unfortunately, cancer has co-opted that pathway, and the cancer cells themselves express PD-L1, and that is the way that cancer evades, one way, the cancer evades immune system attacks. So do normal cells express PD-L1? Absolutely. When we block that PD-1, PD-L1 interaction, are we, in a sense, pulling the parking brakes off of the immune system to help it go and attack normal tissues? Absolutely. That is one mechanism by which immune-mediated adverse reactions occur. There's a good question in here about why the immune system is turned on for so long after the treatment is completed. All right, so who here was vaccinated for the measles at age 5? Right. Who here is still immune to the measles at age 39? Right. Everybody, right? Because the immune system has memory, right? The immune system hangs on to memory like that for a lifetime, essentially. The same thing is true with T-cell stimulating therapy. Once the immune system is taught how to attack something, you have armies of T cells. You have T cells ready to activate against whatever shows up. So when cancers that are treated with immune checkpoint blocking therapies are under control because of immune system attack, the ability of the immune system to continue to keep those tumors under control lasts sometimes for decades. We have patients that are out almost 20 years now after having received ipilimumab that are still, we hesitate to use the word cured, but they are still disease-free, even after having received only 4 doses of ipilimumab, 15 years ago or what have you. Good.
All right, so let's our last case before we get to our closing remarks. A 55-year-old man with Merkel cell carcinoma, severe joint pain and stiffness, no fevers or headache, but there's this polyarticular joint pain. It's worse in the morning, better once up and moving, and we recognize that as this common pattern with rheumatologic diseases. An aspirin, diltiazem, benazepril, history of hypertension, AFib, and they're not taking therapy, right? But we're now pretty wise to what's going on here, right? We've seen case 1 through 6, so we need to be persistent about not just asking about current therapy, but to see what they've already been on, and sure enough, this person was treated with avelumab, 8 months ago, and so this is a case of immune-mediated arthritis.
Right. So as Andrew mentioned, so the 8 months ago is really the key here, and so it really is important to understand what the patient has had for, say, the previous year, to understand that a toxicity may be because the immune system, as we discussed a moment ago, has memory, and you're seeing a delayed immune-related adverse event. There's a question that relates to that here. As an oncologist, do you tell patients that their cough may be an adverse event to therapy and to have their ED provider be aware? So absolutely we tell that to patients. We tell them that any symptom that they experience is potentially related to therapy. We ask that they call us right away which sometimes they do. We ask them to tell ED providers that they are on cancer therapy and to give them the little wallet card that we give to patients that has the name of the drug and our names on it so that we can be contacted. So even with all of those safeguards, sometimes these, toxicities fly under the radar, and but we're certainly trying in all those ways. Do you ever use low-dose steroid prophylaxis, such as patients who are receiving multiple agents? So it's been tried a couple of times and tested in a few different ways. In 2009, there was a publication by a group that used budesonide as a way to try to prevent colitis in patients getting ipilimumab therapy, and it did not. Using prophylactic steroids up front did not prevent the development of colitis. The second thing we know is that if you give steroids concomitant with the first dose of immune checkpoint therapy, you handicap the ability of the immune checkpoint therapy to attack the cancer. So for that reason, we don't use prophylactic steroids. If you could, though, that would make great sense. You would sort of protect the rest of the body and encourage the checkpoint drugs to activate the immune system only against the cancer. We're unable to do that at this point. Can you talk about the cardiac toxicities associated with immunotherapies? What can we expect to see in the ED, specific guidance for assessment and management of cardiac toxicities? Maybe just a brief sentence about what the presentation was on your case. Microphone's coming your way.
Thank you. If you erase the actual patient history, the patient looked very much like a peripartum myocardiopathy.
Oh, wow.
Short of breath, chest pain, big heart and chest x-ray, but obviously it wasn't female, and
yeah, not atypical. Presentation consistent with some sinister cardiac process, often very difficult to tease out whether this is some ischemic event, especially in older people with a cardiac history. Echo shows decreased EF or some, cardiomegaly, what have you, hypo-K and hypokinesis in multiple places or what have you. Like I said before, it's fatal in about 50% of cases, and I think the take-home message for ED providers more than anything is to keep that on your differential. So patients that present with symptoms that could potentially be related to a cardiac adverse event, to know that up front and to keep it on the list, get a stat echo, get a set of cardiac enzymes, that sort of thing. And corticosteroids is the first line therapy for those toxicities as well, though they're oftentimes not as effective as they are in other toxicities. Okay, I'll wrap up.
So, as we think about takeaways, right, as we leave here, so remember, ask about cancer diagnosis and treatment history. Ask about drugs that they've gotten in the last year and beyond. As we've seen, these activate your immune system. Your immune system has a long memory. We don't just want to find out what they're taking now. We want to look back. Number two, get the oncology provider, get the oncologist on your team. One, get you information. But number two, sometimes they can help. I didn't say this before, but for me, they've been a good intermediary between, other specialists. So if I need, if we're ultimately going to need a pulmonologist involved, we're going to need a dermatologist or somebody. Like, I don't want to be making all these phone calls. I have somebody who's familiar with these drugs and seen a lot of cases of these, who's, knows the patient and is working on behalf of the patient and can do a lot of this, behind the scenes communication and care coordination. Remember in your differential to think about immune-mediated adverse effects in any patient, on these drugs that have been on immunotherapy. And then finally, for treatment, the first-line treatment for essentially all of these is corticosteroids, right? So we've presented you here today with 1,000 different organs and possible toxicities, but most of the roads are leading us back to that same place, which is to get steroids on board, in addition to whatever other therapy we would do for the other things on our differential diagnosis. So, with that, we have time for a few more questions.
Let me just answer one that came in here. A cancer patient on checkpoint therapy presents with fever, cough, hypoxia, and a chest X-ray shows new infiltrate suspicious for bacterial pneumonia. How long can the physician safely wait to initiate corticosteroid treatment for IMR-induced pneumonitis after starting antibiotics? Can one wait to see if the patient is not responding to antibiotics? That's a great question. So a patient rolls in, you think that the patient might have a simple bacterial pneumonia. Can you start them on moxifloxacin and wait 24 hours before starting corticosteroids? So as I said before, pneumonitis is one of these toxicities that can move very quickly and can be fatal. So you could. I think, though, that if you have on your list the possibility that the patient has an immune-related pneumonitis, you're probably safer starting a course of corticosteroids first, as well as antibiotics. And it's probably easier to sort through what made the patient better on the back end, or worst case, you just give the patient both a course of 10 days of moxifloxacin and 4 weeks of corticosteroid taper, and you've empirically treated both. But I would encourage you not to delay administration of corticosteroids, especially in pneumonitis, if that is a possibility, if that is on your differential. Yeah. All right, well then we will thank you for your attention. It was a pleasure being with you this evening.
Yeah. Thanks a lot, everybody, and I'll hang around out after here if you have any other questions.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/RQF860. This activity is supported by an independent educational grant from AstraZeneca.